presentation. So without further ado, Dr. Soares.
Thank you for that kind introduction. I think I'm going to stand up on the floor. I prefer to be closer. Okay, good night, everybody. Thanks for the organizers for inviting me. It's lovely to be here again. You'll find out a little bit more about me. I'm from Jamaica, but I do have a solid Bayesian background and some Bayesian family, as I'd call them, so I'm not a stranger. So here we go. So to screen or not to screen, it's about screening for breast cancer. And what screening means is that you're looking for disease early before you actually notice anything, whether a lump or a discharge or something. And, you know, why are they still asking the question? It's been established. And I hope by the time I've finished speaking with you, you'll agree with me that there's nothing really to argue about. It's just for you to decide whether or not you're going to do it, because it is your choice. So these are some of the members of my Bayesian family. As I told you, I'm not a stranger. So somebody, one of my medical students described, you know, oh, there's so much hype about breast cancer and so on and so forth. And the so-called hype started with two sisters, Susan and Nancy Goodman. Susan developed breast cancer at a young age, and she died when she was 36. Her older sister, Nancy, made her a promise before she died not to forget her and to do all she could to help in the fight against eradicating the scourge of breast cancer. So Susan was married, and that's her married name, Coleman, and Nancy got married to Mr. Brinker. So Nancy went on to be quite decorated. She worked in the diplomatic services, and she did a lot of political work. And she established the Susan G. Komen for the Cure and this pink ribbon that you all are so familiar with. That's how it came into being. And this was from in 1982. Ironically, Nancy herself developed breast cancer, but she's surviving. She's in her 70s now, and she's currently a Goodwill Ambassador for Cancer Control by the World Health Organization. So I don't think I'll ask you to stand up, but would you all be kind enough, whoever of you has been affected by cancer of any sort, could I have a show of hands, please? Any kind of cancer. Family, friends, anything. It doesn't have to be personal. All right, so those of you keep your hands up, keep your hands up. So those of you who are affected by breast cancer, keep your hands up, and the other ones, put your hands down. Okay, so a lot of you have been personally touched by breast cancer. So I'm going to show you a few little facts and figures. You know, they have learned organizations that are nicely funded, including the World Cancer Research Fund, the American Institute for Cancer Research. And they collect a lot of information over the years, and they make their estimates for how many cancer cases they expect and what kinds of cancer. They surveil 185 countries, including Barbados and Jamaica. What happened here? Oh, all right. So this is the amount of cases they're predicting. Mr. IT. All right. So they expect to have 17 million cases of cancer be diagnosed in the year 2018. And as you can see from the list, lung and breast are the top two, and they're running roughly the same, 12.3%. Colon and rectal cancer together, third place, prostate, fourth place. So you can already notice that, given the numbers, breast cancer is almost twice as common as prostate cancer. So we're looking at the cancers that will affect women. So breast is on top, right there, 25% of the cancers that will affect women. Colorectal running a poor second, lung and cervix coming down the line. So breast cancer is very common, unfortunately. And, you know, as I said, it's much more common than prostate cancer, and something that I wasn't so sure of, you know, because traditionally you knew that women outnumbered men. Well, not anymore. Men now comprise 50.4% of the world's population. So even though we're now clocking a minority, we're still having more gender-specific cancers than them. And yes, men do get breast cancers, but very rarely. It's less than 1%. So breast cancer is very common, it's devastating, and it needs attention. So the figures show that it's not just common, it's the leading cause of cancer deaths in Caribbean women. That's me in the middle, and that's my sister in her short pants. We used to have an open day in our department. So she lost her fight with breast cancer several years ago, but we keep going. Why do we screen? As I said, because it's the leading cause of cancer deaths. Mammographic screening can reduce the deaths from breast cancer quite dramatically. You're trying to find small, early cancers, okay? You don't want to feel it. By the time you feel it, that means, your prognosis is worse. So you want to try and find it before it can be felt. And several organizations do encourage screening, and some governments actually fund screening programs. So this is just a little map to show you. This was done in 2011. This is the world, as you can see, and the pink countries are the only countries that actually have organized breast cancer programs. So you see that's really a minority. And it's going to be important to remember that when I say a few little other things to you later. So women over 40 are meant to have a mammogram every year. Is everybody hearing me? Okay. If you have a relative who died young from breast cancer, you're allowed to start earlier. And I could tell you about one of my patients. She came in, we diagnosed her at age 28. She actually came in with a lump. Her mother had died from breast cancer when she was 36. So she probably had a genetic component. And I'm sure you all hear this hype about genes and genetics and so on. And it is real, but most women, they can't make that link. So your biggest risk is being female. So you need to pay attention to that. And once you hit 40, your risk goes up. Not to say that if you're younger, it can't happen, but we don't screen routinely younger women. But if you have any problems, you're still going for a check. All right, so here we have what a mammogram looks like. So I'm going to teach you a little bit about my field of business here, my radiology. So this is the right breast, that's the left breast. Right breast, left breast. So you do different views of each breast so you can see as much as possible. And right here, as I like to tell my medical students, what you learn on Sesame Street is very important. One of these things is not like the other. So you put them to match, and when you see something out of whack, it's easier to pick up. And I remember once I got in problem with a patient who had a previous mastectomy. So I had nothing to compare with, and there was diffuse disease all around, and I couldn't decipher it because I had nothing to compare with. So it's a good way of looking at stuff. So this here turned out to be a cancer. And something to remember, we are detecting, meaning we're finding. But when we find stuff, we can't say for sure that this thing is cancerous. So we have to take it out and send to pathology, the guys in the lab, and they confirm before we do anything further. All right, so I know some of you are scared of the machine, and this is what you think you're going to go in, and this jaw is going to squash you to death. All right? So, nothing like that. It's all about technique. And you can see I'm a lady of modest measure. I never had any problems and no pain. So, this is the one, the old-time machine. This thing is not very friendly. And this is the newest of the lot. And there's not much difference from how they look, and I'll explain now how it works out. So for those of you who have never had a mammogram, so the x-rays, because a mammography unit is an x-ray machine, and a mammogram is an x-ray of the breast. All right, so here we have the x-rays coming through here, and we have to have the compression paddle, so it flattens out the breast a bit, keeps it steady, thins it out, spreads the tissue out, so it's easier to see what's going on inside, and it needs less radiation to see what's going on in the breast. And here's a little bit of the anatomy. So this is the chest wall, and your breast is there, And these are the glands that produce milk when you have babies, and unfortunately, that's the same places that the cancers tend to arise. And here are the ducts coming to the nipple. So at your mammogram now, this is where the fat is. Fat here, fat here, fat here. And this is what the glandular tissue looks like. So here's what happens when a cancer starts to grow. This is what the normal duct looks like. And now you see, just nice and neat, one layer of cells. And now you see they're starting to get all over the place, very unruly. That's how cancer behaves, it is unruly. And that's what you call ductal carcinoma in situ. That's very early, and that's when we want to find it. And a lot of times it calcifies these little specks, calcium, and we can catch it early, and we have the best chance of curing. So the bigger it gets, the more likely it is to have started to invade. So we want to catch it when it looks like that. So you do have some problems with mammography. It's not perfect. If your breasts are dense, and remember I showed you the glandular tissue, that's the white-looking thing on the breast x-ray. So if there's a soft tissue mass in it, because sometimes the cancer turns up just with the mass, no calcium, it's hard to find it. And so we have to do other things to help us to make a diagnosis, a detection in those breasts. So that's a problem for mammography, but it doesn't mean we're not to do it, because we'll still pick up the calcium. If you have had any surgery on the breast, the scar tissue can cause some confusion as well. So if you're looking for a recurrence, it makes interpretation a bit challenging. You have a lot of lumps, a lot of calcification, sometimes it's hard to pick up the cancers. And of course, you can have the person reading, they can make a mistake, they can miss something for whatever reason, just human. So there are lots of controversies with regards to mammography. One of the ones you'd hear about is the age story. Oh, you're 40, you're too young to have a mammogram, your breast's too dense, don't do it. Okay, so this was part of the traditional wisdom. They used a magic age of 50 to say once you turn 50, it was fine. If you're under 50, it's not going to work because your breast's too dense, nobody can read anything. But this gentleman, Daniel Copans, he made a very important observation. You do get more fat in your breast as you get older, but it's because you get fatter. And the thing is, we are tending to get fatter at a younger age. So there is no magic age. So here are two of our patients. So this lady is age 50 at the magic age when her breast is supposed to be fatty, but nobody told her. And this patient is 49, and she should have a dense breast because she hasn't crossed the threshold. So this breast is almost pure fat. You're seeing the lymph nodes, the muscle, everything. So it's very, very easy to read a mammogram like that. But it's not impossible to read this one, because you can still see the calcium. And if it's like this, we will do an ultrasound at least to help us to pick up stuff that's hiding. So what we noticed, so she was 49, she had 5 kids and she was 230 pounds. She had 3 kids and she was only weighing 110 pounds, so she had less fat overall. Because you store fat in your breast. So we actually did a study of some of our patients. It was about 800 of them. And what we found, it was their body mass index. That was the main thing. So it was the relative proportion of fat. It tended to go up with their age, but there was no magic cutoff. And we found 3 out of 10 women under 50 to have predominantly fatty breasts, which was much higher than what was commonly reported. But, I guess they weren't looking at it. So, and even though the sensitivity does go down when you are having a younger patient and it's a denser breast, it doesn't mean that it's a waste of time. You're still meant to do it. So we have ultrasound, MR. Well, digital is a different format of using the mammograms, which will be the X-ray. And you also have molecular imaging. Not going to do too much on PET scanning. Some of you might know about that. We usually use it to look at patients who have had a cancer, and we're looking to see if it has spread. So we won't talk too much about that. So ultrasound. So it's very, very good for, it's a good sidekick, if you want to call it, like Batman and Robin. So you have mammo and you have ultrasound. right? So if the patient has dense breasts, you need to do an ultrasound for them. Each time they have the mammogram, it's meant to be routine. And it's actually now law in certain states in the United States. We have been doing it for a long time in Jamaica, from ever since. The breasts were dense, we do the ultrasound, no question. And it was interesting to hear the radiologists complaining that even though they said they were supposed to do the ultrasound, sometimes they weren't doing it. So I don't know. When you find a mass, whether you saw it on a mammogram, you felt it with your own fingers, the surgeon felt it, your GP felt it, an ultrasound is a good way to evaluate it, especially if you're not of age to have a mammogram. And one of the big things with ultrasound, you'll know whether the mass is a lump, solid, or it's a cyst. And if it's solid, you can actually test for tissue, do a biopsy with ultrasound guidance. You can also, if somebody has an advanced cancer or they're thinking that it might be advanced, they can check the nodes under your arms, you know about that story, to see if they are affected. So they use ultrasound for that. And there's some new kind of fancy stuff with the ultrasound, and I'll show you the machine. They now have automated ultrasound. So this is the routine. A lot of you ladies might have had ultrasounds. If you had babies, you'd go for your clinic and you'd get your ultrasound, and they put on the jelly, and it's not painful, it's just a little messy, and they wipe the gel off after. And it doesn't use any x-rays. And this is, so you're using a tiny little probe, but here now, this is a new one with the automated. So the tech puts it in a certain place, puts it in another certain place, and what it does, when it sits here, it scans all the way down. And it's a bit more reliable than if you're scanning yourself because it doesn't leave anywhere out. But there are limitations because it's gauged to the cup size and it's not unlimited for who they can accommodate. So as I say, I'm teaching you some radiology today. So here we have another mammogram. So you notice some round thingies in the glandular tissue. So you do your ultrasound, and this is what you see when you have a cyst. And this is what you see when you have a cyst that's not so friendly. It has something in it. You see there, the picture would say, it have things in there. So you don't want to leave that behind. You need to take it out and sample it. Okay? And here's another one with something on the side. So the first one was just what we'd call a simple cyst. And if it's annoying you enough, we can stick a needle in there and just drain out the fluid, and that's that. But if it has a lump, we have to take the whole thing out and send to the lab. So why can't you use ultrasound? Just ultrasound alone. The detection rate is poor. So we'd miss more than if we did the mammogram. So you use it as a sidekick. And something with ultrasound is very difficult to pick up the calcifications. And that's how we pick up a lot of the early cancers with the calcifications. And that doesn't work so well at ultrasound. So at this point in time, how the technology works, it's not going to happen. You can't do your ultrasound instead of your mammogram. All right? You do have some issues with scarring and stuff. It's a problem with every, you know, it causes confusion when you distort the anatomy after surgery. But as I said, we have other alternatives to help us. And I don't know what the situation is here in Barbados, but, you know, the thing about operator and equipment dependent, ultrasound, Fidel will talk a little more about this, it's one of the cheapest technologies that we have available. And because of that, it falls prey to misuse sometimes. Because people sometimes they buy a machine because they want to charge a patient more, so they do an ultrasound. That's not a problem if you're properly trained how to use it. So that's just a cautionary tale. MRI, we also use for problem cases. You can't see the microcalcs, but it's very good for seeing how the tumor grows into the ducts. Remember the picture I showed you? So when it's spreading, MR is good for that. And the patients who have genetic associations with cancer and they come in early with their cancers, or they're being screened because their sister, their mother had early cancer, in some of the big centers, they do the mammogram and the MR as their screening. It's also good for assessing a breast for recurrent cancer, and also if you have breast implants. I don't know how common that is here, but anyway, that has It's not to do with breast cancer. So here we are. So this is an MR. So the patient is lying face down. So that's why the breast looking like that. They're hanging, they're dependent. So this is the normal breast. Here's the chest wall. And this is the abnormal. You see these things sticking off. You're not meant to have straight lines in your breast. So when we're looking at the images, you see something sticking out like that, something is wrong. And when we give them what we call the contrast agent, maybe some of y'all might call it a dye. It's not a dye, it's a contrast material. It lights up. And they will still have to test it to make sure of what's going on. But that's not a friendly fellow there. MR is very expensive, and sometimes the patients do look like that when they come out of the machine, because if you're claustrophobic, you might not be so happy. With the ultrasound and the mammogram, you don't have to go inside of anything, but you have to do that for MR. So digital, so that's another way of doing the x-rays. So you don't need film, but you still need x-rays. And it gives you a little latitude, because if you have a full digital setup, you can actually use your computer to help you. That's computer-assisted diagnosis. When they started with the digital, they thought they could have got rid of the radiologist so they wouldn't have to pay us. But it didn't work out, because the computers, it overcalls the soft tissue masses, but it's very good for picking up calcifications. And if you have a patient with a lot of stuff going on in the breast, it helps because you can subtract the old film from the new one, and you see what is different. So, I mean, that's kind of cool. So sometimes they use the computer as a second reader. And I showed you the new machine. Sometimes some of them actually do a volume of the breast, and that's called 3D tomosynthesis. So that's the top of the line for digital. Most places don't have that available yet, but I guess that's where they're going. And for those of you who like to watch NCIS and those kind of things, so a little bit of fancy stuff, molecular imaging. It's the same thing as similar to, I don't know if any of you ever had a bone scan or a lung scan, or anybody who had something like that, a thyroid scan. They inject you with some radioactive stuff, and then they take the pictures. So they can do it for the breast. And to show you how it helps, because I can see that something is going on here, but there's no question when you do the molecular imaging, it pops out like a light bulb. So it's easy to miss what's going on here because, you're looking at too much stuff or whatever. Sometimes you just wouldn't perceive it because if you're not seeing it, you're not seeing it. And here is another one. So these are things that we do to help us to detect the breast cancers. So this little cartoon, detect, cause cancer. So the point is, X-rays are not safe. It's radiation, but we use them in small doses. So you have to balance the risk with the benefit, which is why we don't start screening routinely under the age of 40. The rate of breast cancer goes up after 40, and your risk of exposure to the radiation goes down. Children are the most vulnerable because they're growing, and the cells changing fast, and the radiation has the worst effect. And so you wouldn't, like if you have a pregnant person and you're doing a chest x-ray on them, you need to cover the belly and things like that. So you have to balance it. It's all about balance. So I want to mention a few little things here about lifestyle. Metabolic syndrome. Name of a group of factors that lead you to get diabetes, hypertension, heart disease, and stroke. And is also associated with your risk, not only of breast cancer, of cancer in general. And something I don't know if you all know, heart disease is the #1 killer on the planet for men and women. And it's something you can manipulate by your lifestyle. So as they said, large waist, high triglyceride, high cholesterol, high blood pressure, high fasting blood sugar. And they did study almost 100,000 adult women, and they found that metabolic syndrome is associated with an increased risk of breast cancer in adult women. So, as I like to tell my medical students, I get kind of fed up sometimes with being what I call a disease manager. Because we're not about health, we're about disease. You spend years studying pathology and this and histology, and it's all about sickness, sickness, sickness. But we have to try and figure out how to stay healthy. And a part of it has to do with your lifestyle. And the same persons who did those estimates about the numbers of cancers we'd have diagnosed in 2018, these were some of their suggestions. Be a healthy weight, be physically active, eat whole grains, fruit, limit fast food, limit processed food, and limit alcohol, sweetened drinks, don't rely on supplements. And you notice the word limit. They don't tell you don't do this, don't do that, right? They say limit, moderation in all things, and stay active. Go dancing, it's wonderful. All right, so reminding you again of the recommendations. Start at age 40. You start earlier if you have a history, a family history. And the thing is, it's kind of a little funny because they say 10 years earlier than the person was diagnosed, like your mother or whoever. But you don't normally know when they were diagnosed. You know when they got sick, or you know when they died. So it's kind of a gray area. But I mean, if you come in for mammography, you're 30, and you say, boy, my mother was 37, and I know she was sick from breast cancer, nobody's going to argue with you. They'll start screening you. And they had this thing about doing a baseline at age 35. I don't know where that came from, but it's gone. So don't let anybody tell you need to have a mammogram when you're 35, unless you have the right history. So we still show decrease in death rates. They're still arguing about this mammogram story. I don't know why. But anyway, some of them complain about the money of doing mammograms. I know, as you saw from that map with the pink, most of the countries on the planet do not have government programs, so women have to pay for their own mammograms. So whose money are you saving? And the next thing is now, I went through this with my sister, and for a year, she had to have surgery, chemo, and radiation. And this was a rough figure, 50,000 US for 1 year worth of treatment. She had to have all those things. A mammogram probably would cost $40, right? She was diagnosed late. And the thing about it, as I said, you screen, you catch it earlier. Treatment is less devastating. It's cheaper, you're more likely to be cured. One of my oncology colleagues jumps up and down all the while and she says she wished mammography was compulsory because it's so expensive to treat cancer. Sometimes they talk about the anxiety. Oh, you're causing anxiety in the female population. Oh, the women get so worried. Well, so I decided to look and see what were the causes of anxiety in women. So if you read the newspapers, like I think I got this out of Huffington Post, but anywhere you'll see dear pastor, dear whomever, and these things always come up. Your relationships, your finances, your body images. You're too fat, you're too skinny, your bust not big enough, blah, blah. You just lost your job. People get worried about that. And guess what? Doctors make everybody anxious. There's actually a name for it, iatrophobia. And there's such a thing as white coat hypertension. People become clinically hypertensive because they're scared of doctors and they have to be treated for the high blood pressure. I never knew that. So, I mean, the thing is, I'm reading and I'm looking for stuff that speaks to the fact that mammograms make people anxious. And I haven't really found anything much yet. Oh, yes, so our chair is there reminding about HIV testing. This was put out by this health center, speaking to their patients. What could we do to help you feel less nervous when you come to the hospital? And so now I'm looking for the scientific journals now. What is there in women? So I type in anxiety in female patients, whatever. And these came up. They had articles about anxiety in colonoscopy. You know, you're going to have a colonoscopy and what they needed to do to reduce it. People having cardiac cath. And with regards to the breast, there were a lot of articles on anxiety related to the treatment of breast cancer, not to screening. Patients having a mastectomy, going for chemo, going for radiation. There were papers published about that. And last but not least, the one that had the most hits was pregnancy and childbearing. Had no idea. That was the commonest documented and researched cause of anxiety in women the world over. PRA, pregnancy-related anxiety. Never heard of it before. It's well documented. So I say, if you're worried that women will get anxious about stuff and you're going to tell them don't do it, well, tell them don't get pregnant. So there's been a lot of stuff of investigation about breast cancer screening. They have done lots of trials, lots of this and that, and we could be here till next month and we haven't gone through all the papers, so I'm just making a quick note. It started with the HIP, Health Insurance Plan of Greater New York, and they did one of the first major trials with data from 1963 to 1982. So this is from back in the day. I'm sure a lot of you weren't even born in 1963. And they found that screening mammography saved lives. And this is where the recommendations came from. A few years ago, this was in 2002, the US task force threw some major cats among the pigeons, and they were saying, oh, you need to stop doing mammography. You know, they did some statistical correlations. They're not clinicians, they're statisticians. And so they did some big counts. And they said, oh, you're over-treating cancer, and the women 40 to 50 don't need to come, and blah, blah. And everybody who was anybody in the mammographic breast imaging world jumped down their collective throats. And they said that if they knew which cancers were going to kill the patients, they wouldn't take them out when they found them. And some of the doctors actually went further to say they didn't know which one of their patients would have volunteered to be the ones who died because they didn't screen them. So, just 2 weeks ago, I found this update from the same set. All right, so they did an update for the U.S. Preventative Task Force screening for breast cancer. And this is the punchline. So they wanted to update the evidence since 2002. They said they were screening average women 40 to 49, 70 or older. Mammography screening reduces breast cancer mortality for women aged 39 to 69 years. Data are insufficient for older women, 69 and up, right? They didn't say it don't work, they just said they didn't have enough figures to work it out. They don't know. False positive mammography results and additional imaging are common. So remember I told you sometimes we had to do ultrasounds and stuff to help to clarify. So it is a fact. It's not perfect, but it's the best we have for now. They said no benefit has been shown for clinical breast examination or breast self-examination, and I will speak to that now. It is not a substitute for mammography, but it can't hurt. And our colleague has just come back from Africa and said the women don't have mammography, because I actually saw a study that was done on breast self-examination, and they said if you're in a country in a setting where mammograms are readily available, they say it's almost a waste of time to do breast self-exam. But there are that's not for the majority of women actually on the planet. And the thing is, you need to know what your breasts feel like, what they look like. And as I have said, mammograms are not perfect. You might miss something, whether because of how the breast is, or it's maybe too tiny to pick up. You need to pay attention, and it's once a year you're doing the mammogram. So if you feel a lump, you see blood from the nipple, any watery stuff, you need to go to your doctor, right? So as I said, it's not a substitute, but it is something that can be very useful, especially for women who do not have mammograms available. So, poor little lady. Anyway, so as I said, despite the problems, mammography remains the primary screening tool. Speaking to the younger patients now. So, we don't start if you're under 40. So I know we have a couple of under 40s here, quite probably several. Never ignore a lump. Conference I attended in, when was it, April this year? So they had a panel speaking about the importance of mammographic screening. And one of the persons on the panel was a breast cancer survivor. She was diagnosed when she was in her late 20s. She found a lump in her breast. She wasn't from here, she was from the United States. She found a lump in her breast. She said her mother taught her to examine herself to make sure that she took care of her body. She understood what her body was up to. She found a lump, she went to the doctor. Can I have a mammogram, please? No. Can I have a mammogram, please? No, you're too young to breast cancer. Lesson number one, you're never too young to get anything. We screen certain populations because it is more common in them. You don't screen if the risk is low. So we don't screen under 40, but that does not mean that you're exempt. You find something, you have it checked out. So I remember saying to her that if she had been, it was like, I don't know how much longer it took her and how many more physicians before somebody finally did some investigation. And I told her that if she had come to our practice, what we'd have done is an ultrasound, and we'd have stuck a needle in there and sent it to the pathologist. So we would have picked her up. I think by the time she was diagnosed, she had axillary nodes. But she's doing okay so far. I mean, that was a horrible story. I don't know if anybody in their right mind could tell the patient that they're too young to get cancer. Rubbish. All right, so if your patient is young, as I say, you start with ultrasound. You never ignore a lump, never ignore a double discharge. So the older patients, they don't routinely screen over 60, 65, and the figures from the task force, their upper limit was 69. And the thing is, the rule of thumb that I've come across, if you have somebody who is fit and healthy, and you think they might live for another 10 years, go ahead and do the mammogram if they want. That's not an issue. We had a patient once, she was like 84, and she came in, she had cancer that had spread. And I'm like, you know, maybe she had had her mammogram when she was 70, maybe they had caught it early and she wouldn't have had, because she had a horrible fungating tumor. So it's age-related, it's condition-related. Because if you have a younger patient who has terminal renal disease or something, there's no point screening. Don't need to torment them with that. But, you know, as I said, my poster girl is Jane Fonda. I think she's heading for 80 now, and boy, she looks fantastic. She probably lives to be 105. So I don't know if anybody would have a right to tell her, no, don't have her mammogram if she wanted. So if you expect, you're fit, and the longer you live, the longer you're likely to live. And my generation not doing so good. All right, so we're winding down now. So mammographic screening saves lives and it saves money. You have the right to choose. Do not let anybody discourage you. As I said, it's your choice, but don't let anybody tell you any foolishness. Go ahead. Remember this lady reminding the ladies not to give up their power. And that's me at your animal flower cave last year. Thank you very much.